All right, let's get started. Um, so I know this is slated to be an hour and a half long, but I don't think we'll take that much time, and I don't think I can actually talk that long. But we will get into the down and dirty about cystic fibrosis related diabetes, focusing on how we can use diabetes technology beyond type 1 diabetes. And I am an adult and pediatric endocrinologist. I see adults with cystic fibrosis here at MGH and have been for the past decade or so. And I also do clinical research, really trying to find ways that we can use diabetes technology to improve diagnosis and treatment of CFRD. So I'm really excited that you're here to hear about this. Here are my disclosures. And what I'm hoping we will accomplish over the next hour or so is to first, I want to give you a little background about CF-related diabetes, or CFRD, as we like to call it. And then I have two cases, patients of mine, that I think really nicely illustrate some of the challenges in the diagnosis and management of CFRD and how specifically we can use diabetes technology to address some of these challenges. So for all of the non-pulmonologists, which are pretty much all of us here in this room, a little background about CF. So it affects about 40,000 people in the US and 105,000 worldwide. This condition is due to dysfunction of the CF transmembrane conductance regulator protein, or CFTR. It's autosomal recessive. It affects multiple organ systems, the upper and lower respiratory tract, pancreas, lots of different organs, but we typically think about it in terms of the progressive pulmonary decline, which is the primary cause of mortality in this patient population. And I have to tell you, it is such an exciting time to be taking care of people with CF because there are so many new and effective treatments that have improved the quality of life and life expectancy. And so this, back in, I think it was like the 1960s, the average life expectancy for a child with CF was 10 years old. And now for children born between 2018 and 2022, their median predicted survival is 56 years of age. And this is only getting better with time. And a big driver of these improvements in life expectancy have been the development of highly effective CFTR modulator therapy. And this is just changing the landscape of CF care. So these are medications that are pills, they're taken orally, and they actually improve the function of the CFTR protein and have been shown in studies to improve lung function and to improve nutritional status with significant improvements in BMI. And so the newest of these modulators, which is this one, elexacaftor, tezacaftor, ivacaftor, was released into the world, or into the US first, in 2019. And you can see there's been rapid uptake of these medications. And anyone who has one copy of the Delta F508 mutation, which is the most common CFTR mutation that we see, then those patients are eligible for this medication. And so you can see now here in 2022 that the vast majority, almost 90% of patients with CF are on a CFTR modulator. And seeing the improvements that these patients have on these medications, it's been really special. But what we're finding is that as people with CF are living longer, non-pulmonary complications are becoming increasingly prevalent and burdensome. And so diabetes is one of the big ones for this, one of the most common non-pulmonary complications. And this is data from the CF Foundation Patient Registry from 2022. And you can see here in red is impaired glucose tolerance and blue is CF-related diabetes. And really, you can see starting in the around pubertal age, we see a rise in diabetes such that around up to 20% of adolescents and somewhere between around 40% of adults are affected by this condition. And CFRD does share some characteristics of type 1 and type 2 diabetes, but it really is its own unique form of diabetes. The primary driver is insulin deficiency that's caused by beta cell dysfunction and destruction, we think related predominantly due to the exocrine disease and fibrosis that's occurring in the pancreas. In the beginning, patients will often have very mild insulin deficiency where they're just seeing prandial hyperglycemia. So the blood sugars just go high after eating, but fasting is fine. And then this over time will progress to a more significant, substantial insulin deficiency that looks a lot more like type 1 diabetes and requires basal insulin. In this condition, there's also increased insulin resistance as well. And this is typically due to just really significant underlying illness, inflammatory cytokines, stress hormones, worsened when patients are sick with the CF exacerbation or when they're needing to take steroids. There's also very controversial data that CFTR itself may be actually expressed in beta cells and playing a role in the CFTR dysfunction, in the insulin dysregulation that occurs. But the real reason that we care about CFRD is because it has been shown that the development of diabetes has an impact on CF-specific clinical outcomes. And so we know that in really any diabetes state, that insulin deficiency and hyperglycemia can have toxic effects. So we know that insulin deficiency leads to a catabolic state, be associated with weight loss, which is particularly bad for people with CF who often struggle with nutrition to keep their BMI into the normal range. We also know that hyperglycemia in general is associated with an increased risk of infection. And this is also an issue for people with CF because they are already at risk for lung infections related to their disease. And interestingly, there have been some studies that have found elevated glucose levels on airway surfaces in people with CFRD when the blood sugars go above around 140. And this can lead to bacterial growth. It can also cause an exaggerated but less effective inflammatory response. And so this can be, in general, this is why CFRD can have a negative impact on clinical outcomes and has been shown to be associated with poor nutrition, a decline in BMI, with reduced pulmonary function, increased CF exacerbations, and earlier mortality, particularly in women. And in addition to this, we also know that CFRD can cause, just like diabetes in any population, microvascular and macrovascular complications. But these are much less commonly reported in people with CF, and these complications tend to occur at a lower A1C than other diabetes populations. And this is, again, data from the CF Foundation Patient Registry looking at complications of CFRD in 2022. You can see overall, especially in the kids, but also in adults, that overall, these rates are actually very low. But I also think we're not doing a great job of screening, I'll be honest with you, so that may also be playing a role. I'd also point out that this isn't included on the list, but I've also seen gastroparesis a lot in my patients with CFRD, and that can be really challenging since they tend to have a lot of GI issues already. So the onset of CFRD tends to be insidious, and starting really with a gradual development of postprandial hyperglycemia that over time develops into fasting hyperglycemia. And so the CF Foundation recommends that all patients, especially given the prevalence and the impact on clinical outcomes, that all patients over the age of 10 be screened every year for diabetes. And the oral glucose tolerance test is the screening test of choice. And the reason the OGTT was chosen in particular is that this test and the diagnosis of diabetes by this test has been correlated with important clinical outcomes like pulmonary function, BMI, and mortality. But the reproducibility is poor, and many barriers exist to getting this testing done. And so this is, again, data from the CF Foundation Patient Registry looking at the annual rate of OGTT screening. And you can see that we're really doing a terrible job with screening. So this blue, the blue line is really any glucose screening. And here this green line are OGTTs that are done every year from 2003 to 2022. The dotted line are ages 10 to 17, and the solid line are adults. And you can see that in adults who have the highest risk of diabetes, only about 30% of people with CF were screened in 2022. And, it fell off a little bit, with COVID, but we weren't even doing great before that either. So really a screening test is only helpful if it is actually used. And we are missing the opportunity to diagnose diabetes early in our patients because no one's getting this testing done. It's a real challenge in this patient population. And there are actually multiple ways to make the diagnosis of CFRD. And so we typically think about, for people who are healthy outpatients, we look at the oral glucose tolerance test. And in this test, it's typical criteria that we use for all forms of diabetes with fasting more than 126, a 2-hour more than 200. Also, if a patient has an A1C of above 6.5, that's also diagnostic of diabetes. Or if, just like with other diabetes populations, a random glucose above 200 with symptoms. And all of them should be repeated in order to make the diagnosis, except for that last one. Now, unique to CFRD, you can also make the diagnosis of diabetes if a patient is receiving overnight tube feeds, which is not uncommon, and it's as an approach to improve their nutritional status. If they have high blood sugars during or after the tube feed, confirmed on 2 separate nights, and the blood sugar is above 200, that can be used to make the diagnosis. And then also we can make the diagnosis during a period of acute illness. If people have fasting hyperglycemia or 2-hour postprandial hyperglycemia occurring that's persistent for more than 48 hours, that can also make the diagnosis. And in terms of treatment, we know that the early initiation of insulin can lead to improvement in all of the bad things that diabetes can cause in this population. It can improve pulmonary function, improve nutritional status, and indirect data suggests that there may also even be a mortality benefit. And so for this reason, insulin is the only recommended treatment for CFRD at this time, really because no other medications have been able to show this kind of improvement in CF-specific clinical outcomes. And the recommended glycemic targets that we use for people with CFRD are the same as what we use for all other diabetes populations. Now, but I think it's important to point out that these targets were established based on the development of microvascular complications. And again, yes, our patients are at risk for microvascular complications, but that's not what we're worried about. What we don't have are any studies telling us what our targets should be to improve or to prevent problems with CF-specific clinical outcomes. And so we might actually benefit from CF-specific glycemic targets. We just don't know. It's another gap in the medical literature right now. So with that background, I wanted to dive into the 2 cases that I wanted to tell you about. I think these are just really good examples of how diabetes technology is in the process of and will continue to improve the diagnosis of CFRD in this case, and then the next case we'll be looking at treatment. So this is patient AR. This is a patient of mine who's 17. He has a history of CF. He is Delta F508 homozygous. He has pancreatic insufficiency, which 90% of the patients do. He also has really struggled with nutritional status, and he had a G-tube placed in the past for nocturnal tube feeds. He started CFTR modulator therapy and right around the time it came out, and he had significant improvement in pulmonary function, but unlike many people, he actually did not have any improvement in his weight gain. And so he was really struggling with getting his BMI into the target range. It was 10%, and he's in the 10th percentile, and we aim for the 50th percentile. From a lung perspective, he's doing really, really well and had a great lung function with an FEV1 of 99th percentile, which is great. And he had no recent hospitalizations or treatment with steroids. And he is very good about going and doing his annual OGTTs. So I want to show you some of his OGTT data. So in 2018, he had a screening OGTT, and his fasting glucose was 108 with a normal 2-hour, and his A1C was 5. And so this puts him in the category of impaired fasting glucose. In 2019, very similar. He again had impaired fasting glucose. And in 2021, because we skipped everything during the pandemic, in 2021, his fasting glucose, again, still in that impaired fasting glucose range, but now he also has impaired glucose tolerance with a 2-hour glucose between 140 and 200. So now he has kind of a combined picture. And then in 2022, he has a 2-hour glucose of above 200, and so then qualifies as CF-related diabetes based on this test right here. And so I'd like to point out to you something interesting about these data, and that is that he basically went from impaired fasting glucose to CFRD with really no change at all in his hemoglobin A1C. And so this is something that I think is really, really fascinating, and I want to talk more about. But first, I want to do a poll question. Bob, can you pull up this poll for everybody? All right, wait for it. Here it is. Okay, so enter in your answer. Why is hemoglobin A1C falsely low in people with CF? Is it accelerated red blood cell turnover? Is it chronic hypoxia? Is it lab error? Or it's not falsely low? Okay, so we're getting answers for the first two, accelerated red blood cell turnover and chronic hypoxia. Excellent. Okay, we can end the poll. Oh, share results. So these are the primary answers. So interestingly enough, the answer is actually, I would like to argue, and you can tell me if you believe me or not, it's actually D. It's not actually falsely low. I learned in residency and even in fellowship that, it was accelerated red blood cell turnover, chronic hypoxia. This was causing the A1C to not reflect actual red cell glycation. But we recently published this study where we actually used CGM and we collected between 14 and 42 days of CGM over two times over a 3-month period in 77 adults with CF, both with and without diabetes. And the data that I'm showing you here is the average glucose by CGM on the y-axis, and then A1C on the x-axis. And these dots, the blue triangles are normal glucose tolerance, the pink squares are abnormal glucose tolerance, and the purple circles are CFRD. And this line in between them is the linear regression equation with the relationship between the two. And as you can see, A1C and average glucose by CGM are actually very tightly correlated. And so even more so, this green line right here, and this, well, actually, let me start. The orange line is the same relationship that was published with the A1C derived average glucose, or the ADAC study. And that was a study in over 500 people with type 1 and type 2 diabetes in healthy volunteers. And so as you can see here, there's really no difference between our line in our study with people with CF and the line of people with type 1 diabetes and type 2 diabetes. And then this green line right here is a study that was performed by Dr. Chan at the University of Colorado, looking again at this relationship in a group of children and adolescents with CF. And again, you can see these lines are all very close. And so what this data tells us is that really A1C is strongly correlated with average glucose. It doesn't underestimate glycemia in people with CF, and it does so similarly as in other diabetes populations. But that does not mean that A1C is a good screening test for CFRD, and I want to show you why. So this is an example of a CGM profile for a patient of mine who has early CFRD. And you can see here, so we're looking midnight to midnight, and then average glucose values are here on on the y-axis, and we're seeing all of her glucose data over a 14-day period on this single slide. And here is her median glucose over this 2-week period. And as you can see, for the most part, is well within the 80 to 140 target range. But, and you can also see her average glucose is 117 with an estimated A1C of 5.7%. So that's great, right? But if we look and see what's happening on a day-to-day basis, we're seeing that this patient is having significant prandial excursions to the 200 to 300s with almost every meal, but these excursions are often followed by reactive hypoglycemia. And so even though her average glucose is okay, any measure of average glucose is not going to be able to capture this glycemic variability that's happening early in the course of CFRD, and that's why that's not a good screening test. Now, hopefully I've convinced you. All right, so I have another poll question. Bob, pull it up, here we go. Okay, so the OGTT showed CFRD, and whenever we see that, really, we need to repeat it to confirm that that's actually the case. But this patient was not willing to come back to confirm it, which is very few actually are willing to do that test again. And so now what are our next steps? We can start a low dose of Lantus, or we can start a lispro-carb ratio with meals, so short-acting insulin with meals. We can ask the patient to do finger stick checks before meals and after meals, or we can place a CGM. And we are, in fact, at a talk about diabetes technology, and so it makes sense that everybody is saying, D, place CGM. And that is exactly what I would do. I'll tell you though, even like 5 years ago, I would have been doing C because, CGM wasn't as widely available. It was harder to do. It wasn't as accurate. And so we would often, like some people do finger stick checks, they check a couple fasting in the morning that are normal, and then they stop checking. And it was really challenging to actually get good data. And then for other patients, especially if they're, lung, they had compromised pulmonary function, or we were really worried about them, sometimes we would just start insulin, either a low dose of Lantus or Lispro. So I think in the past, we tended to do those much more, but now CGM has been so helpful in this exact scenario. All right, so what do we know about CGM in CF? So I'll tell you that CGM has been validated in people with CF and has been shown to be both accurate and reproducible in this unique form of diabetes. Secondly, we also know that CGM measures of hyperglycemia and glycemic variability correlate with both lung function and BMI. And interestingly, even people with normal glucose tolerance on oral glucose tolerance testing have been shown to have abnormalities on CGM that have been associated with worse lung function and a higher risk of infection with certain bad types of bacteria like Pseudomonas and Staph aureus. And interestingly, we learned from CGM studies that even very young children, as young as 2 to 3 years of age, have dysglycemia, and really it's telling us that these abnormalities may be occurring much earlier in life than we previously appreciated. And so we did CGM for this patient, and this is what his report looked like, which is kind of amazing. So average glucose 108, 99.1% time in target range, 0.6% time above 180. And when we look, we can see that this patient is having some glycemic excursions, but they weren't really bad at all. And certainly no room in here where we would be able to safely start insulin without causing potential hypoglycemia. And so now remember this number right here, because the hard part about, I will say, using CGM is that, well, we don't actually know what cutoffs we should use to diagnose or treat diabetes in people with CF based on CGM alone. And so I wanted to show you the data from the study I just told you about. In this study, we were really interested to see if there were any CGM measures that could distinguish people with and without diabetes, really as a way to try to lay the groundwork for one day potentially using CGM as a screening tool. And so with using data from this study, we constructed these ROC curves and comparing those with diabetes and without diabetes. And we calculated the optimal cutoff for distinguishing these two groups, maximizing both sensitivity and specificity for predicting diabetes. And so I'll show you of these, percent time above 180 and above 140 were particularly promising. And you can see here, 3.4% was the cutoff that we found that was able to distinguish those two. Our patient that I just told you about, his was 0.6. So very much below that. We also did a separate validation sample in 22 people with CF with or without diabetes. And the ones that did have diabetes were very early in their course and were not on any insulin treatment. So kind of similar to a screening sample. And we found similar predictive value for both of these measures. And so it's not enough to say that we should start using CGM for screening by any stretch of the imagination, but it's very promising that we could really potentially one day move in that direction. Now, I'll tell you, literally, so that was published in the Journal of Clinical Endocrinology and Metabolism, and literally the month before that came out, this paper was published by Dr. Chan, who's a friend of mine at the University of Colorado. And they did a study, and they actually also constructed ROC curves and calculated cutoffs for distinguishing people with and without diabetes. And they actually found that CGM did not perform as well in distinguishing those with and without diabetes. And I think the big reason here is that our populations were very different. Her population had a mean age of 13, a very low risk of diabetes. They were much healthier, and only 13 of those patients had diabetes versus over 30 of our patients had diabetes. In addition, they used 5 days of CGM data collection with an iPro system, and we had almost a month worth of CGM data in our patients. And so really, I think that this message here is that what we need are bigger, larger prospective studies where we can look and identify how CGM can be used as a screening tool in predicting really important CF-specific outcomes so we can one day, my goal, my dream is to one day use this in place of oral glucose tolerance testing. All right, so back to our patient. So we decided, given his, CGM findings, and given the fact that, from a pulmonary perspective, he's really already doing very well, we ended up deciding that we would not start any treatment and that we would just continue to monitor annually with an OGTT versus, plus or minus the CGM. And so he also asked us if his OGTT results, developing diabetes, because it really happened right after he had started highly effective CFTR modulator therapy with elexacaftor, tezacaftor, ivacaftor. And so he was wondering if potentially that medication pushed him over the edge to diabetes. And so this is another example of just how helpful CGM can be, particularly in a clinical research perspective. And so what we did was back when this medication was first approved by the FDA, we put CGM sensors on people before they started treatment, and then we aimed to do it 3 months after they started treatment, but then that was like right in the middle of COVID. So it ended up being more like 8 months after they started treatment. We found, interestingly, that treatment with this patients who were treated in this group had significant improvements. This is the total cohort here in black in their average glucose. And then also in time spent in hyperglycemic ranges got lower. And their time in target range actually got better after they started treatment with ETI. And this was most pronounced in those who had had diabetes, but even those people without diabetes had less time in hyperglycemic range after starting treatment. Now, this doesn't necessarily mean that ETI itself is affecting beta cell function There's so many things that happen when people start ETI. They're healthier, they may be getting more exercise, they may be eating better, they may have less inflammation, lots of things going on. But overall reassuring that it's unlikely that in his case, our patient's case, that ETI made him worse. And since then, I will say there have been more studies looking at oral glucose tolerance testing effects, ETI effects on glycemic status, and really doesn't seem to be having a huge effect. But it'll be interesting to see as people are treated younger and younger, if we start to see any other kind of reduction in the development of diabetes. That said, we're also seeing more obesity, so we might start to see more type 2 diabetes phenotypes. And so we will always have a job in CF endocrine, no matter what. I'm not concerned about losing my job. All right. So next up, we're going to talk about our second case. And this is really focusing on using diabetes technology in the management of CFRD. And so I want to start off by pointing out some of the unique challenges that our patients with CF face in managing their diabetes. And the first one is that so many of my patients spend hours of their day just taking care of their lung disease. And so when we add diabetes tasks to this, finger stick checks, insulin injections, carb counting, on top of everything else that they're already doing, it can really be overwhelming for many people. In addition, people with CFRD have a very variable degree of endogenous insulin production. So early on in the course of CFRD, someone may only need like 2 or 3 units of short-acting insulin with meals, whereas in someone who's had diabetes for a much longer time or who's much sicker, has a lot more insulin resistance, they may be on 50 units a day with both long-acting and short-acting. And so, and really anywhere in between. And it can change over time, which is another really challenging part, is that people with CF will often get sick and have lung infections, and that will lead to higher insulin resistance and a higher insulin requirement. And they may need much less insulin when they're healthy. And it can be a lot to keep up with. In addition, people with CF often have a higher caloric requirement. BMI and pulmonary function are very tightly linked, and it's very important to get that BMI in the normal range. And that requires a lot of calories, and carbs have the most calorie dense of all of the foods. And so a lot of times that can lead to high sugar intake and high carbohydrate intake. Also, like I showed you in that CGM tracing earlier, people with CF are at risk for spontaneous reactive hypoglycemia, we think due to a very well documented delay in first phase insulin secretion that can occur in CF. And so it can be hard to start insulin in a patient who's already having a lot of hypoglycemia. And then lastly, all of these things can have an impact on people's quality of life. These are all of the areas that we hope we can potentially try to improve with diabetes technologies. So what do we know about the use of diabetes technology in the CF community? And the answer is not much, but this was a study that we did a few years back where we sent out a survey to the CF Community Voice program, which are people with CF or parents of children with CF. And we asked people about diabetes and about technology use. We found that of those people who answered the survey who had diabetes, about 75% of them reported using CGM, which is actually a lot. And but about a third of those users actually stopped using CGM, with the primary reason being excessive cost. And then about 29% of these people who responded to the survey reported using an insulin pump, which is probably lower than what we would see in type 1 diabetes. But again, almost a third of the people had stopped using the device for various reasons. And so really, this tells us that we have work to do to ensure access to and sustained use of diabetes devices and technology in this patient population. All right, so here is my patient that I want to tell you about. He is a 32-year-old. He has CF, pancreatic insufficiency, moderate lung disease. I initially met him, and he'd been diagnosed years before based on oral glucose tolerance testing, and was managed with just a typical multi-dose or multiple injection per day with Clargine and Lispro for many years. His BMI was lower than we would like. It was 18. Our goal is 23 for men with CF. And his pulmonary function was about 55%, so moderate lung disease. And he would be the first to tell you that of everything, diabetes management has always been one of his greatest challenges. And fitting with that, when I first met him, his A1C was 12.2%. And so room for improvement. And so this was when I was kind of, younger and earlier in my career. And I was just sure that we were going to get this better. And we did counseling, education. I made frequent adjustments to his regimen. We met frequently. And despite these best efforts, we just could not get his A1C below 11 over that next year. And really, this was because he just wasn't checking his fingerstick glucose levels, and he was just missing long and short acting insulin injections. And I'll tell you, people with CF have a little bit of endogenous insulin, even in the most, advanced of cases. And so that's usually enough insulin to prevent them from going into diabetic ketoacidosis. And so it's really rare for someone with CF to have DKA. And so it means that they can live with A1Cs that are very high for a very long time without getting to a dangerous point. And I think so it really, missing the long-acting insulin was really, really hurting us in this case. Okay, Bob, I have another poll question. All right. So what would be our next best step in management of a CFRD? We can refer to an online CFRD education and support group, of which there are some really great ones, I have to tell you. We can start a non-insulin medication to help with his glycemic control. We could change him to an insulin smart pen and try ultra rapid acting insulin, or we can recommend a CGM. All right. Excellent. Okay, so it looks like our answers are tied between a type 2 diabetes medication and changing to starting a CGM is winning now. It is about technology. So any CGM answer is probably going to be the right one. And then last up is the smart pen. So again, to be honest, it's kind of a trick question because none of these are wrong per se. But I'll try to explain to you why I think CGM is actually the best answer. So here we go. Before we do that, I wanted to just kind of take a step back and tell you about how things in CF are really changing when it comes to oral medications and type 2 medications for people with CF, because it used to be that most people were underweight. And now with highly effective modulator therapy, we're starting to see a lot more people in the overweight and obese category. And so this was a study that looked at one of the older but very effective CFTR modulators, which is ivacaftor, and they followed patients over 5.5 years, both pediatric and adult. And up here at the top are the overweight and obese. And you can see that, especially in adults, there was a significant increase from 24 to 36% of the population who were actually weighed too much instead of too little. And you can also see, especially in adults, far fewer were in the underweight category. And so this is kind of changing things when it comes to medications, type 2 medications in CF. So this was one of the original studies that compared repaglinide, which is used for type 2 diabetes, with insulin in people with early CFRD who had normal fasting glucose but had prandial hyperglycemia. And in this study, which was a total of 61 people with CFRD, here in the red are insulin, and you can see prior to starting treatment, there was a decline in BMI, and then starting insulin led to sustained improvement in BMI over the next 12 months. Now, here's placebo, where we saw no change. In the repaglinide group, there was a transient increase, which is the black one right here. There was a transient increase in BMI at the 6-month mark, but that was lost by the 12-month mark. And so really this kind of supported the idea that, insulin is what will help our patients with sustained improvement in their nutritional status more than other non-insulin therapies. And then since then, there have also been multiple studies looking at other non-insulin therapies. Now, I'll say in metformin, there's very limited data, and there are some case reports that it seems to be safe. There have been studies shown here where GLP-1 agonists may improve islet cell function and improve prandial hyperglycemia in people with CFRD. There's another study suggesting that DPP-4 inhibitors may improve insulin secretion, but did not have an effect on glucose levels. There have been no studies at all in SGLT2 inhibitors. And also, if we look at medications, the alpha glucosidase inhibitors like acarbose, these have been shown to reduce prandial excursions and may be helpful to treat reactive hypoglycemia. But in particular, the GI side effects can be pretty challenging. And in all of these medications, what we really have to be careful about in people with CF specifically are the potential for weight loss. And so as an example, for our patient that I told you about, his BMI was right around 18. We have no room for him to lose weight, especially because his pulmonary function, because BMI and pulmonary function are so tightly correlated, we might actually make him worse if we were to start a medication that would cause him to lose weight. The other big issue, especially with the GLP-1 therapeutic class, is the effect on gastric emptying and again, the GI side effects. Many people with CF and CFRD already have risk of gastroparesis or potential for delayed gastric emptying at baseline. So we have to be really thoughtful and careful about who we choose to start these medications. That said, I have treated probably upwards of 6 or 7 around adults with GLP-1 agonists who were obese with and without diabetes for weight loss. And so far, so good. So I think really we need more data, especially now in the post-Trikafta era. All right, insulin smart pens. So again, it's not the wrong answer to start a smart pen. I have many patients with CF and CFRD who are using the smart pen and find it very helpful to kind of track their insulin and to help them calculate the doses. So no published studies at all, but anecdotally, I think many patients like it. I will say I do tend to use a lot of ultra rapid acting insulin in people with CF. And so this, as you know, ultra rapid acting insulins have a faster onset than your typical rapid acting insulin here in the gray. And so at the top, this is a CGM tracing for someone who's having reactive hypoglycemia with CF. And what I found is that if we use the ultra rapid acting insulin and we dose that, we can sometimes help prevent this prandial peak that's occurring and then therefore prevent the low that's happening in response to that. And again, this is partly due to a delay. So people have some degree of endogenous insulin production, and there's a delay in first phase insulin secretion, followed by a more exaggerated second phase insulin release that's predisposing them to this reactive hypoglycemia. And so ironically, I have actually started ultra rapid acting insulin to prevent hypoglycemia in people having reactive hypoglycemia by trying to prevent this hyperglycemia that's happening right here. So it takes a lot of timing and diligence, and I only do it when someone has CGM, but I do think that there may be a potential role there. But again, completely unstudied in the CF population. This is all anecdotal data, I'm telling you. All right, back to our patient. So although at first he was very reluctant to be attached to something all the time, eventually I wore him down and he started using the Dexcom G5. And he found it actually very helpful. It just kind of reminded him to take his insulin, and it took away needing to do all the finger stick checks, although this one did require calibration. And so just 4 weeks after starting CGM, his A1C already improved from close to 12 to 9.3%. And here is his CGM data. So you can see here, average glucose, which before would have been in the 2 to 300s, 167 using the Dexcom G5, 59% time in target range, and overall with a GMI of 7.3%. So really the best I'd ever seen his blood sugars was when, and he was doing calibrations consistently. So, so the G5 really seemed to work well for him. So what do we know about CGM in the CF population? So the answer is, again, not that much, but this was a really interesting study where investigators collected 3 days worth of CGM data and then used that to guide insulin initiation in 37 of the 59 patients. And so they actually started insulin. There was a different intervention, but they found that in this group, starting insulin improved pulmonary function and weight gain at 3 months, and that these patients had a lower rate of pulmonary function decline with insulin treatment. And they also had improved glycemia with insulin. So again, this isn't really looking at the effect of CGM, but shows how we can use CGM in this patient population. And then I think a huge gap in the medical literature right now is that we have no randomized clinical trials investigating CGM in people with CFRD who are already on insulin, although there is a trial that's going to be starting in Australia in the near future, which is very exciting. There was a meta-analysis and systematic review that looked at a whole bunch of different studies, most of which were observational, at looking at CGM compared to finger stick, and it had to be a minimum of 6 weeks of CGM use. And they found that overall, there was a 0.4% improvement in A1C with CGM use, which is not too dissimilar to what we see in the type 1 diabetes and type 2 diabetes population. The effects of CGM use on pulmonary and nutritional outcomes were conflicting, but unfortunately, really, there's not that much we can conclude from this because the quality of the studies was poor with a very strong potential for bias. So really, we do need more data. All right, and then so back to my patient. So, oh, whoops, he skipped one. So he did great for a while with the CGM, but then, you know, life kind of got in the way and he had a series of stressors that kind of just took his attention away from diabetes, and he kind of fell off the wagon. He stopped using CGM, and his A1C was right back up to 11.6%. In March of 2020, my clinic moved to 100% telemedicine due to the COVID pandemic, which has actually been amazing for my patients because I can see so many more people. They don't have to come all the way into Boston and fight all of this crazy Boston traffic to see me anymore. And so when I saw this patient, we actually, he was back in a better headspace and able to move forward with diabetes treatment. We upgraded to the Dexcom G6. He started using it again, and he agreed to try insulin pump therapy. So what do we know about insulin pumps in people with CF? And again, it's not surprisingly, the answer is not that much. And so this was a study that looked at 9 adults with CFRD as they transitioned from multiple daily injections to insulin pump therapy, and then followed them over a 6-month period. And we can see that they had significant improvement in their weight and lean body mass. They had improvements in their blood sugar levels, and had a higher insulin dose, trend toward improvement in A1C. But I'll point out that this study was published in 2009. And so our pumps today look a lot different than what they looked back then. So our patient, this is his CGM data when he was doing multiple daily injections using the Dexcom G6. So he had an average glucose of about 200. Then we started a hybrid closed loop insulin pump, which is in this case, the Tandem t:slim X2 with Control IQ. And this was his data after. So improvement in his average glucose to 147, which is with GMI of 6.8, which is the best I'd ever seen since I'd met him. 77% time in target range, just with this transition. And so really, this patient did very well with this treatment. So he also was one of the patients, the 13 patients that we included in this retrospective chart review. We collaborated with investigators at the University of Minnesota to look at all of our patients that had transitioned from CGM and multiple daily injections to Control IQ. The data that I'm showing you here is their average sensor glucose for all of these patients from midnight to midnight. And in blue is their baseline glucose data when they were just using multiple daily injections. And the shaded is the interquartile range. And you can see after 3 months of using Control IQ, the red shows a significant reduction in their average glucose across the day and the night, with significantly less glycemic variability as well. So bringing them into much closer into the target range between 70 and 180. So it seems that for the most part, hybrid closed loop pumps can be helpful in people with CF, but again, very little data. Back to our patient. So he did very well with Control IQ. But it's like what happens with time, his average glucose is creeping up and, his time in target range maybe creeping down a little bit. And he still spends a lot of time and effort on managing his diabetes. And so he's very excited about the newest diabetes technology. And so then he also participated in our CFRD bionic pancreas trial, which I'll tell you about right now. And so as you may know, the iLet bionic pancreas, which was recently FDA approved for type 1 diabetes and in ages 6 and above, this particular device is different from the other hybrid closed loop pumps that are available. It requires only weight for initialization, and then it automatically adjusts insulin levels based on CGM glucose and adapts to individual insulin needs and continues to adapt even when those needs change, which is particularly helpful for people with CF who often do have changes in their insulin needs. There's no carbohydrate counting is required. Instead, you can do qualitative meal size announcements. It's typical meal, less typical, greater than typical, but it takes away the need to do carb counting. And correction boluses are all automated. So the user, even if they wanted to give a correction bolus, they couldn't. It's all automated. So it's really the most automated device that's available for now. And the data in type 1 diabetes was published in the fall of 2022 and showed about a 0.5% reduction in A1C with over a 3-month period with this device compared to standard care. And then we recently published a study using this device. It was a random order, open label, crossover design clinical trial where we randomized 20 adults with CFRD to either the bionic pancreas or usual care for a 14-day period. And then they switched to the other one for another 14 days. And there were no limitations on diet, exercise, work, anything. And then with this, in this trial, we found that our primary outcome, % time in target range, that there was significant improvement from 63 with usual care to 75, bringing over that 70% threshold with the bionic pancreas. Each line here represents an individual in the trial, and the red line shows everyone together. And then the circles show how much hypoglycemia these patients were having. And so you can see the improvement in % time in target range, and hypoglycemia really didn't change over the course of the study. And so we, using this data, we are now moving forward with a randomized multi-center clinical trial that's funded by the CF Foundation, where we will be, we'll probably start enrollment in the next month or so. And so we'll be randomizing people to either usual care or the bionic pancreas over 13 weeks, followed by an extension period where everyone uses the device for the next 13 weeks. And our goal is to be able to get FDA approval for this device for people with CF, in order to kind of remove some of the barriers that our patients have to face since they don't have type 1 diabetes, to be able to improve access to this technology and to ultimately be able to offer this to all of our patients regardless of insurance. So this trial is also exciting too, because it'll give us the opportunity to look at outcomes like BMI. We'll be looking at microbiome changes, just to really, and also looking at GI symptoms, other secondary outcomes, to try to see, how does glycemic control and improvements in glycemic control affect other CF specific outcomes. So that's very, very exciting. Stay tuned on that one. I also wanted to take this opportunity to tell you about some of the other studies that are ongoing in the CF population, because it's just such an exciting time to be in this field. And there's so much that we still have to learn to know how to best take care of our patients. And so with the onset of highly effective modulator therapy, there was kind of basically like an explosion in pregnancies, because women were so much healthier and were able to become pregnant and also, live long enough to take care of their kids. It's just such an amazing phenomenon to watch. But we don't know anything about diabetes in pregnancy. There's so few studies looking at this. And so the Mayflowers, or Maternal and Fetal Outcomes in the Era of Modulator study, funded by the CF Foundation, is an observational study enrolling women who become pregnant and then following them prospectively over time and following their children after they're born. As part of this, we're doing a CGM sub-study where we're putting CGM sensors on women at 4 time points during pregnancy and then again after pregnancy. And I think this study is going to be so important to give us insights on the glycemic abnormalities, the clinical impact, how we should be screening our patients during pregnancy, how we should be treating them, all of these great questions that we can look at with this study. So very excited about this one. And then the other one I wanted to just briefly tell you about is, I talked a lot about BMI, and BMI is tightly correlated with pulmonary function. But one thing that we're seeing is that as people are gaining weight, and we're seeing more overweight and obesity in people with CF, BMI seems to be, not telling us the full picture. And, we've been seeing, cases of sarcopenic obesity where people, like, their BMI is fine, but their lean mass is actually very low. And so the STRONG CF study, which is strength and muscle-related outcomes for nutrition and lung function in CF, is a multi-center observational study of about 20 sites across the US that is collecting all sorts of markers of nutrition, including body composition, sarcopenia measures, frailty measures, following patients prospectively over time, to really help us kind of peg some of these other nutritional measures to outcomes in people with CF as a potential better way to gauge nutritional status in this patient population. So we have about 70 people enrolled in this study out of an expected 300. And so I think this will be another really exciting study in CF. And we also are getting, of course, CGM in this study as well. So, all right. So with that, I wanted to kind of summarize the last hour and then also leave time for questions that anyone might have. So I hope I've convinced you over the past hour that CFRD is common, affects up to 20% of adolescents, 30 to 50% of adults, and it's associated with important CF-specific clinical outcomes, including pulmonary function decline, compromised nutritional status, and earlier mortality. And because of these associations with these important outcomes, it's really important that we diagnose this condition early. But onset is insidious, and our screening test that we recommend, the oral glucose tolerance test, it's just really hard to get this testing done. And nationally, screening rates are very low. And so we're missing the opportunity to diagnose patients early with this condition because no one's getting screened. Also, insulin right now is the only recommended treatment for people with CFRD. And the reason is that insulin is the only one that's really been shown to improve clinical and nutritional status. But, and I will say, as we start to see more obesity, more overweight, more metabolic syndrome, as people are gaining weight and living longer with CF, I do believe that there is going to be a role for some of these non-insulin therapies for people with CF, and including the GLP-1 agonist family of medications, including SGLT2 inhibitors, especially with their renal protective effects. So I think that really this is going to be a very important area of future research in this patient population. And lastly, this is such an exciting time for trying to see and investigate and use diabetes technology in this patient population. And I think that I hope that I've described how this technology, CGM and insulin delivery devices, can really be helpful for addressing some of the unique needs and challenges of this specific patient population. All right. And with that, what I might do is actually stop sharing and see if anyone has any questions. Let's see, how do I do that? Stop share. Yes, okay. Yes, anyone have any questions, any personal experiences managing people with CF or cases I can help with? Funny stories, jokes, anything?
Hi, I had a quick question.
Yes.
I'm wondering how you manage folks with CFRD who are receiving, for example, overnight tube feeds. What kind of insulins do you use?
That is such a great question. And I have very strong opinions about this too. So I'm glad you asked. So for people who are on like just injections and MDI regimen, I have found with a lot of trial and error that a mixed insulin regimen, 75-25 or 70-30, so it's like 70% NPH, 30% Lispro, that really tends to work the best. Because most of the time, the tube feeds overnight are lasting about 8 to 10 hours. And so NPH will be good for covering over that window. The problem is that if you don't have that short-acting insulin up front, what can often happen is that they start to go high right away. By the time the NPH is kicking in, you've already missed the window, and then they're going to be high most of the night. And sometimes even and if you keep going up on the NPH, then they're just going to start to drop low in the tail end. So I really like either a 75-25 or a 70-30 injection with the tube feeds. Now, for insulin pumps, it's a different story, and I have different approaches for each of them. So for people who are using, let's start with Control-IQ. What you can do is actually have different basal programs. And so when they are using the tube feeds overnight, they have a basal program that has a much higher basal rate just overnight. And so then Control-IQ will fluctuate around that higher basal, and that has worked pretty well. They just have to remember to bring that down and use a separate program, another basal program. We usually we'll label them, basal tube feed, basal no tube feed, or something like that. But they'll have to switch it to the other basal program if they are not using the tube feeds, because otherwise they might drop low. The algorithm can sometimes figure it out, but it's better to be able to switch back and forth between that. For the Omnipod 5, it's really hard. This one is really hard. So for just the regular Omnipod or the Omnipod 5 in manual mode, one thing you could do is just, again, do the higher basal rate overnight. And so a lot of times I'll do that in manual mode. We'll raise the basal to 3 units an hour, sometimes more, and then cover the tube feed, and then you can bring it down, ramp it down at the end. And again, they just need to be able to toggle back and forth between basal programs to account for days they're not using the overnight tube feed. So manual mode is doable. unfortunately, the Omnipod 5, the way it works is it takes the basal rate over the 24 hours over the past 3 days, and then it gives half as the set basal. So if you do that, it's going to think that that overnight tube feed is actually basal requirement, and it just doesn't work. So either you can push it into manual overnight, but you lose that ability, you're losing that automation when you do that. So you can push it into manual. The other thing we have also tried is to give an injection of 75/25 to cover the tube feed separate from the Omnipod 5. And so if you do it well, you're basically covering the tube feed carbs with that. And then, you know, ideally the Omnipod 5 would then really only be covering, you know, the basal overnight. It's just really hard to get that perfect. And so you still might, in auto mode, overestimate your basal need requirements during the day, since it's basically setting that basal for the full 24 hours. I wish it were a little different, make it easier. For the iLet, we actually, in our trial, we had one patient who was on overnight tube feeds during the trial. And so for him, we also had him do his injection, because again, the iLet is going to think that that's basal, and you won't be able, it won't know when you're not giving the tube feed. You can't tell it, you can't change the basal programs. So you won't know, and the device won't know when you are or are not having overnight tube feeds. And so you really can't just let it do its own thing, because on days you're not getting a tube feed, it's going to be too much. So for that, what we did was we gave the patients 75/25 dose at the start of tube feeds to cover the tube feed overnight. And that actually worked out pretty well. And I haven't had any Medtronic patients with CFRD. So I don't know how I would manage that one.
That's super helpful. Thank you.
Yeah.
I guess for the folks that are on CIQ overnight, then do you turn sleep mode off so that they get the corrections overnight, or do you leave them on sleep mode but just ramp up the basal slowly until you get it?
Yeah. So I'm trying to remember. I think we tried it both ways. I think we've typically left sleep mode off so that you are still getting the corrections if they're high, because usually when people do tube feeds, they tend to go higher, and they're definitely, you know, higher above the 110 target. So I think it tends to work better with sleep mode off, but you could try it both ways. It's a lot of experimenting, I have found. So the good news is that the number of people with CF needing overnight tube feeds is like much lower now with Trikafta. And so I haven't had, I think now, much different than before, I only have a few people who are still on tube feeds. But hopefully that's one thing that we'll see less and less of with time. It's hard. It's hard.
Yeah, for sure. Thanks so much.
Yeah. Yeah, that's a great question. I'm so glad you asked. Great. So I just put my email in the chat. So feel free to reach out if anything comes up. And thanks so much for watching.